Imagine walking into a clinic, feeling deeply insecure about a part of your body.
Right, which is already a huge hurdle for a lot of people.
Exactly. You finally work up the courage to ask a doctor to fix it, but instead of scheduling a surgery, the doctor hands you a catalog.
A catalog.
Yeah, a catalog to prove that you are completely anatomically normal, and then they refuse to operate on you.
It just completely shatters our standard expectation of what going to a cosmetic doctor looks like.
It really does.
I mean, usually you bring a problem, you bring your credit card, and, well, they give you a solution.
But today, we are diving into a space where that standard transaction is fundamentally flipped on its head. Welcome to the Deep Dive. I'm your host.
And I'm your resident expert.
And today, we are looking at a medical field where intense personal vulnerability collides with incredibly aggressive marketing. I'm talking about the multi-billion-dollar world of intimate procedures and female genital cosmetic surgery.
Which is a sector that has just exploded over the last decade. I mean, they're promising everything from aesthetic perfection to complete rejuvenation.
Right. But beneath those glossy billboards is a heavily contested ethical battleground.
Absolutely.
And that is our mission for you today. We are going to cut through that marketing noise to discover exactly how truly ethical clinics navigate this space. Specifically, we want to know how the best practitioners manage to discuss and set realistic expectations with their patients.
Because they're often telling them things they absolutely do not want to hear.
Yeah, exactly. To figure this out, we've pulled from a massive stack of sources. We've got policy documents from clinics, regulatory warnings from the FDA and Australia's TGA.
Right. They're really heavy hitters.
Yep. Plus the strict ethical guidelines laid out by the General Medical Council, the American Urological Association, and the Royal College of Obstetricians and Gynecologists.
But, we aren't going to just list off a bunch of rules today.
No, nobody wants that.
We need to look at what actually happens in the room. Because before a scalpel or a laser is ever brought out, the most crucial and, honestly, the most intense medical intervention happens right there in the consultation chair.
I want to start right there, actually, with the consultation, because when you read through these clinical guidelines, you realize the very first hurdle an ethical clinic has to clear isn't medical.
No, it's educational.
Right. It's educational. There is a staggering disconnect between what a healthy adult vulva actually looks like and what society thinks it should look like. And patients are walking into these clinics completely blind to their own anatomy.
The data on this is actually quite alarming. There's a recent study we looked at by El Hamamzi and colleagues that tested patient anatomical knowledge.
And what did they find?
They found that up to 40% of patients seeking these services are unable to correctly identify basic genital structures.
Wow.
Yeah. We are talking about nearly half of the patients not knowing the difference between the labia minora and the labia majora.
If you're listening to this, put yourself in the shoes of a surgeon for a moment. If a patient comes to you desperately wanting a piece of their anatomy surgically altered, but they can't even point to it on a diagram.
Or tell you its correct medical name.
Right. How can they possibly give informed consent for you to cut it off?
They cannot. Legally and ethically informed consent requires comprehension, and that forces the ethical clinician into a very difficult position.
They basically have to pause the cosmetic consultation and become a biology teacher.
Exactly. This is where those guidelines from the Royal College of Obstetricians and Gynecologists, the RCOG, really come into play.
Okay, let's unpack this. Because the RCOG makes it a strict foundational requirement for clinicians to sit down and discuss the incredibly wide biological variation of what constitutes a normal adult vulva.
They literally have to deprogram the patient.
It's like, okay, think about taking your car to a mechanic when you don't even know what a carburetor is. You're absolutely convinced your engine is destroyed. But instead of popping the hood and charging you $5,000 for a rebuild, the mechanic sits you down with a catalog of hundreds of different perfectly functional engines to prove yours isn't broken.
And to achieve that deprogramming, clinics rely on specific, evidence-based educational tools. They aren't just sketching on a notepad here.
What kind of tools?
Well, some utilize a resource called the Great Wall of Vulva.
Oh, yeah, I saw this in the sources.
It's a fascinating art and education project. It features plaster casts of over 500 different labia.
Which is brilliant because it takes something heavily stigmatized and hidden and puts the sheer, overwhelming physical diversity of it right in front of your face.
Exactly.
We treat these natural variations in female anatomy as medical problems to be fixed, when in reality they are as biologically unique as fingerprints.
Yep. There's also the Labia Library, which is this online database of non-airbrushed, non-modified photographs, and a really direct pamphlet from Brooke, simply titled, "So What's a Vulva Anyway?"
I love that title.
It gets straight to the point. But using these tools isn't just about anatomy, though. It's actually a psychological screening tool.
How so?
Well, the RCAG guidelines point out a profound mechanism at play here. Requests for labial reduction are very frequently a psychological displacement.
Displacement, meaning the anxiety isn't really about the tissue itself.
Precisely. A patient might be dealing with a profound lack of self-worth, or relationship trauma, or severe generalized anxiety.
Yeah.
But those feelings are abstract. They're incredibly hard to fix.
Right.
So the brain displaces that anxiety onto a physical, tangible target. The patient thinks, if I just cut away this asymmetrical tissue, I will finally feel clean or acceptable or lovable.
So the clinic isn't actually performing physical medicine at that moment. They are performing a psychological reset,
Yes.
which totally explains why the RCAG states that a psychological referral in primary care needs to be a primary consideration before a patient even sees a gynecologist for surgery.
It forces the clinician to dig into the why. You see this really clearly with pain syndromes. A patient might demand a labiaplasty to cure vulvodynia.
Which is a condition characterized by chronic, unexplained nerve pain in the vulva.
Right. And an ethical clinic has to hit the brakes there and firmly explain that surgery is absolutely contraindicated for this.
Because you can't surgically remove a pain syndrome. If the issue is neuropathic-like, if the nerves themselves are misfiring, cutting off a piece of tissue isn't going to stop the nerve from sending pain signals to the brain.
In fact, cutting into it could create scar tissue that makes the nerve pain exponentially worse.
So they're unwinding years of misinformation. Once that baseline of normal is established, ethical clinics really have to dig deeper into the patient's individual history, which leads directly to how they share the burden of decision-making.
And this was the part of our research that fundamentally changed how I view this entire field of medicine.
Same here. When we look at the American Neurological Association's guidelines, they strongly endorse something called the SHARE approach.
Yes, the AUA white paper is very clear on this.
It's a structured framework for shared decision-making. Can you break down that acronym?
Sure, the SHARE acronym is essentially a roadmap for returning agency to the patient. It stands for seek the patient's participation, help them explore and compare options, assess their values and preferences, reach a decision together, and evaluate that decision.
What really struck me is the emphasis on explicitly asking the patient, what matters most to you right now?
It strips away that clinical hierarchy.
Yeah, and making sure they know declining treatment is a completely valid option. But a huge part of that is the AUA's mandate for trauma-informed care.
This is critical.
Clinicians are instructed to actively inquire about past traumas before they even think about doing a physical exam. We are talking about screening for childhood maltreatment, sexual violence, and intimate partner violence.
Which is a heavy burden to place on a cosmetic or gynecological consultation.
Right. And if I'm playing devil's advocate for a second, I really have to wonder about the practicality of that. Like, if you're a listener sitting in a waiting room because you want treatment for severe menopause symptoms and the doctor suddenly starts asking about your childhood trauma, that feels invasive. Doesn't exploring a patient's history of abuse slow down the clinical workflow tremendously?
Well,
Why is a psychological history suddenly a mandatory part of a physical pelvic exam for something like menopause?
if we connect this to the bigger picture, it makes perfect sense. Because the psychology dictates the physiology.
Okay, how so?
Trauma isn't just a memory stored in your mind. It physically alters the architecture of your nervous system. When a person experiences significant trauma, their brain essentially installs a hypersensitive alarm system. The sympathetic nervous system gets locked in a state of hyperarousal.
The classic fight or flight response, but just never fully switches off.
Exactly. Now, think about what your body does when you are startled or stressed. You tense your shoulders, you clench your jaw.
Yeah, of course.
The pelvic floor muscles do the exact same thing. They reflexively guard and contract. Over years or decades, this chronic subconscious clenching alters local blood flow and sensitizes the local pain receptors.
So the muscles are just perpetually exhausted and starved of normal circulation?
Yes. So let's take a condition like genitourinary syndrome of menopause, or GSM, which those AUA guidelines cover extensively. GSM involves severe dryness, tissue thinning, and irritation due to a drop in estrogen.
Right.
If a patient with GSM also has a history of trauma, their central nervous system is already amplifying threat signals, and their pelvic floor is already physically guarding. The baseline trauma makes the physical pain of GSM, or even just the pain of a medical exam, exponentially worse.
Wow. So if a doctor ignores the trauma, they aren't just lacking empathy, they're fundamentally missing half of the physical diagnosis.
And they risk doing active harm. An ethical clinic creates a safe environment to avoid re-traumatization during exams. They use this trauma history to fundamentally alter how they deliver care, ensuring they don't trigger that hyper-aroused nervous system.
What does that look like in practice?
It means explicitly offering chaperones. It means the doctor explains every single physical movement before it happens. It means securing ongoing, verbal informed consent before any physical contact is made, and giving the patient the power to stop the exam at any second.
So realistic expectations aren't just about telling the patient what their body will look like after a procedure. It's about setting expectations for how the care itself will be experienced. It's about creating safety at every single touch point.
Exactly. But, maintaining that slow, careful, trauma-informed approach is incredibly difficult,
Oh, I bet.
especially when that same vulnerable patient has just spent weeks being bombarded by algorithms selling them a miracle cure.
Ah, yes. Here's where it gets really interesting. Because if patients are seeking a fix for complex psychological distress, hitting trauma, and physical pain, they are the absolute perfect target for aggressive marketing.
They really are.
I'm talking about the explosion of the vaginal rejuvenation market, specifically lasers and energy-based devices.
This is where the tension between slow, ethical medicine and fast, commercial enterprise absolutely peaks.
You see these ads everywhere, billboards, Instagram, TikTok. They promise to fix literally everything. Bladder leaks, use the laser. Painful intimacy, use the laser. Don't like how you look, zap it with the laser.
It's marketed as a magical, painless Swiss Army knife for every conceivable pelvic issue.
Right. But when you look at how ethical clinics handle these devices, they treat them like a highly targeted prescription medication. You wouldn't take a cough drop to fix a broken leg.
Definitely not.
So you shouldn't use a laser meant for specific tissue atrophy to fix complex sexual desire issues or cosmetic insecurities.
And the regulatory bodies have had to step in very aggressively here to combat this marketing.
Yeah, the FDA warnings were pretty severe.
Very severe. The FDA in 2018 and Australia's TGA both issued strict safety communications. They explicitly warned against the use of energy-based devices, specifically fractional CO2 and erbium lasers, when they are marketed under the umbrella of cosmetic vaginal rejuvenation.
And they backed up those warnings with terrifying adverse event reports. They cited serious risks like deep scarring, severe burns, and persistent, intractable pain.
It's awful.
Yeah, and the professional bodies like RANSCOG and ACOG chimed in too. They stated unequivocally that these procedures are not medically indicated to improve sexual function or body image.
To understand why the marketing is so deceptive, you have to understand the mechanism of what these lasers actually do. A fractional CO2 laser works by inflicting controlled thermal damage. It vaporizes microscopic columns of tissue in the vaginal wall.
It literally blasts microscopic holes into the skin.
Yes, and the body's immune system panics. It senses the thermal injury and rushes blood growth factors and fibroblasts to the area to build new collagen and heal those microburns.
So it's essentially tricking the body into repairing itself by injuring it first.
Exactly.
Which completely explains why the real-world medical data on this is so nuanced. When we look at the Frontiers cohort study, which tracked 826 women treated with these lasers for that menopause condition, we discussed GSM, the results were really specific.
It's very specific.
For patients suffering from dyspareunia, which is pain caused by the surface tissue becoming thin and fragile, the long-term responder rate was an impressive 88%.
Because the laser triggered collagen production, which thickened and plumped that fragile surface tissue.
Right, but the study showed those same lasers were highly ineffective for issues like stress urinary leakage. And if you think about the mechanism, it makes perfect sense.
Yeah, because urinary leakage is a deep structural issue.
Exactly. It's the muscular hammock of the pelvic floor failing to support the urethra. Using a surface laser to treat urinary incontinence is like trying to fix a crumbling house foundation by putting fresh wallpaper on the living room walls.
I love that analogy.
I mean, it might look plump and rejuvenated on the surface, but the structural integrity causing the leak hasn't been touched at all.
That is a perfect encapsulation of the problem. And it is exactly what an ethical clinician has to explain to a patient who just paid for a consultation because a billboard promised them a cure for their bladder leaks.
How do they even have that conversation? Like, sorry, the billboard lied to you.
Essentially, yes. Managing expectations here means an ethical practitioner must explicitly disclose those FDA and TGA warnings as a mandatory part of informed consent.
Wow.
They have to explain the wallpaper versus foundation reality. Furthermore, they must break down the reality of the treatment protocol. The marketing implies a quick one-and-done zap.
Right, in on your lunch break, out by one.
Exactly. But the reality of energy-based device therapy for GSM requires multiple sessions, typically 3 to 5 spaced weeks apart, and it almost always requires ongoing maintenance top-ups every year.
It's a chronic treatment for a chronic condition, not a magical cure.
And the most vital part of managing that expectation is defining the risk of failure. The clinician has to look the patient in the eye and say, this intervention might not achieve your desired aim. Your body might not produce the collagen we want.
Because biology doesn't read the marketing brochure. Now, if these ethical clinics are this incredibly rigorous inside the consultation room, if they're spending an hour resetting normal anatomy, exploring childhood trauma, and debunking laser hype, they must also be tightly constrained in how they get these patients into the waiting room in the first place.
Oh, without a doubt.
Because you certainly can't run a trauma-informed medical consultation off the back of a flash sale.
You absolutely cannot. The regulatory bodies recognize that vulnerable patients can be exploited before they even meet the doctor. This is why there are incredibly strict rules governing how ethical doctors market their services, how they obtain consent, and how they manage aftercare.
We looked closely at the 2016 General Medical Council rules in the UK, which are closely mirrored by internal clinical policies we reviewed, like those from Ripon Medical Services.
Right. The GMC rules are foundational here.
And the GMC explicitly states that doctors cannot use promotional tactics that encourage ill-considered decisions. This means stripping all the gamification out of medicine. No discounts, no loyalty schemes.
No countdown timers on a website.
Exactly. And absolutely no offering cosmetic procedures as contest prizes.
It firmly separates medical care from retail commerce. Another critical mandate from the GMC is regarding who actually takes the consent. The doctor performing the procedure, the person holding the scalpel or firing the laser, must be the one who takes the consent.
They can't just pass it off.
No, they cannot delegate that conversation to a slick clinic coordinator, a salesperson, or an assistant.
And clinics must enforce a mandatory cooling-off period. You can't just walk in, have a consultation, get emotionally fired up, and go straight into the procedure room. You have to go home, sit with the information, and think about it.
Which is vital for true consent.
But as I was reading through these GMC rules, there was one mandate that really made me stop and question the balance of power here.
The primary care requirement.
Yes, the GP requirement. The rules state that doctors performing these private elective procedures are required to share written information about the treatment with the patient's general practitioner, their primary care doctor, to ensure continuity of care. Right. Now, I have to push back hard on this. If I am a private citizen and I am paying out of my own pocket for a private, elective, highly intimate cosmetic procedure, I am doing that precisely because I want discretion.
Sure.
Why does the GMC insist my private surgeon basically tattle on me to my family GP? Does that feel like a massive paternalistic invasion of my privacy as a consumer?
This raises an important question, and it's a very common reaction. But it assumes that cosmetic medicine exists in a vacuum, completely separate from your overall biological health.
Okay.
The GMC enforces this rule because ethical medicine is holistic. By involving your GP, the private clinic ensures that a safety net is built underneath you.
A safety net for what, exactly?
Well, let's say you have a surgical labiaplasty and you develop a severe systemic infection 2 weeks later. Or the trauma of the procedure triggers a major depressive episode. Or maybe you need long-term pelvic floor physical therapy.
Right.
If your primary care team has no idea what was done to your body, they're flying blind when trying to save your life or manage your recovery.
Okay, I see the medical logic there. But what if the patient simply refuses? What if I say, absolutely not, do not call my GP?
You always have the right to deny consent. But if you do, the rules dictate that the private doctor performing the procedure takes on the full burden of your holistic care.
Meaning what?
They take full responsibility for 247 out-of-hours follow-up. They cannot just perform the procedure, take your money, and disappear.
Wow.
It forces the surgeon to realize that they aren't just altering a piece of tissue. They are taking responsibility for a human being. It underscores the GMC's ultimate foundational rule. If a doctor believes an intervention will not ultimately benefit the overall well-being of the patient, they must not provide it. period.
You cannot buy an ethical doctor's compliance just because you have the cash. So, what does this all mean for you, the listener, if you are trying to navigate this incredibly complex space?
It's a lot to weigh.
It means that a truly ethical clinic is, first and foremost, a clinic that is entirely willing to say no to you. It's a practice that prioritizes your anatomical education over their aesthetic portfolio.
It's absolutely.
It's a doctor who uses shared decision-making to honor your specific biological history, asking about the trauma your nervous system might be carrying to ensure you are safe. And they flat out refuse to use cheap retail marketing tricks to bypass your right to fully informed, sober consent.
It is a standard of care that actively resists the commodification of the human body.
But looking at all of this, the sheer effort it takes to protect patients from themselves and from the industry, it leaves us with a really provocative thought to end on.
Sarah.
We've seen through the sources just how much immense profitable pressure there is in our culture to medicalize completely natural, healthy variations in human bodies. We talked about those plaster casts and the breathtaking diversity of normal anatomy.
Right, the Great Wall of Vulva.
Yeah. So think about this. If society were to actually fund comprehensive education, like if we all fully embraced the vast natural diversity of our physical anatomy from a young age, would this multi-billion-dollar cosmetic medical industry as we know it today even need to exist?
That's a great point.
If we all finally understood that the engine wasn't broken in the first place, would we keep paying mechanics to try and rebuild it?
A very powerful question to leave our listeners with.
Thanks for taking the deep dive with us today.